Okay, Chapter 10, Airway Management. The single most important step in caring for patients is to address life threats, and a primary component of that is ensuring that they can breathe adequately. When the ability to breathe is disrupted, oxygen delivery to tissues and cells is compromised. Oxygen reaches body tissues and cells through two separate but related processes known as breathing and circulation. There's a diagram of the anatomy of the respiratory system. I would become familiar with each thing and where it's located and what it's called. The respiratory system consists of all the structures that make up the airway and help us breathe or ventilate. The airway is divided into the upper airway and the lower airway. Anatomy of the upper airway. The upper airway consists of all anatomic airway structures above the vocal cords. So your upper airway is going to be everything that is above your vocal cords, such as your nose, your mouth, your pharynx, and your larynx. The main function of the upper airway is to warm, filter, and humidify air as it enters the body. Your pharynx, a muscular tube extending from the nose and mouth to the level of the esophagus and the trachea, composed from top to bottom of the nasopharynx, oropharynx, and laryngeal pharynx. The nasopharynx, lined with ciliated mucous membrane that filters out dust and small particles. It warms and humidifies air as it enters the body. Oropharynx is posterior portion of the oral cavity. The epiglottis is superior to the larynx, and the epiglottis helps prevent food and liquid from entering the larynx during swallowing. Your larynx is a complex structure formed by many independent cartilaginous structures. It marks where your upper airway ends and your lower airway begins. The thyroid cartilage forms a V shape anteriorly, also known as the Adam's apple. The cricoid cartilage, also known as the cricoid ring, forms the lowest portion of the larynx. And then the cricoid thyroid membrane, which is the elastic tissue that connects the thyroid superiorly to the cricoid ring inferiorly. The glottis, or the glottis opening, is the area between the vocal cords. And then the vocal cords are the white bands of thin muscle tissue. At rest, they're partially separated. They help produce speech, and they also protect the trachea from the entry of substances like water or vomitus. The anatomy of the lower airway. The function of the lower airway is to deliver oxygen to the alveoli. The lower airway includes the trachea, which is the conduit for air entry into the lungs. Trachea is also known as the windpipe. It begins directly below the cricoid cartilage, and it descends anteriorly down the midline of the neck into the thoracic cavity. In the thoracic cavity, the trachea divides at the carina into two main stem bronchi, which is left and right. The bronchi are supported by cartilage, and they distribute oxygen to the two lungs. There's your diagram. On entering the lungs, each bronchus divides into even smaller bronchi, which divide into bronchioles. Bronchioles are made of smooth muscle. They dilate and constrict as oxygen passes through them. The smaller bronchioles connect to alveoli. the site of oxygen and carbon dioxide exchange. Alveoli are millions of thin-walled balloon-like sacs. Alveoli are surrounded by blood vessels known as pulmonary capillaries. The oxygen diffuses across the alveolar membrane into the pulmonary capillaries. Oxygen in the pulmonary capillaries is transported back to the heart and distributed to the rest of the body. Carbon dioxide diffuses from the pulmonary capillaries into the alveoli where it is exhaled and removed from the body. The thoracic cavity also contains the heart and great vessels, the vena cava and the aorta, which are important for respiration. The mediastinum, which is the area between the lungs, contains the heart, the great vessels, the esophagus, the trachea, the major bronchi, and many nerves. And also the phrenic nerve is found in the thorax, which allows the diaphragm to contract when it's necessary for breathing to occur. The respiratory and cardiovascular systems work together. Ensure that a constant supply of oxygen and nutrients is delivered to all of the cells of the body, and it removes carbon dioxide and waste products from the cells. There's you a table. I don't know what page it's on in your book, but it's the physiology of breathing. Ventilation is the physical act of moving air into and out of the lungs, which is necessary for oxygenation and respiration to occur. Inhalation, the active muscular part of breathing. The diaphragm and intercostal muscles contract during inhalation, which allows air to enter the body and travel to the lungs. The lungs require the movement of the chest and supporting structures to expand and contract during inhalation and exhalation. Partial pressure is the amount of gas in the air or dissolved in the fluid, such as blood. Oxygenated arterial blood from the heart has a partial pressure of oxygen that is lower than the partial pressure of carbon dioxide in the pulmonary capillaries. The body attempts to equalize the partial pressure, which results in oxygen diffusion across the membrane into the blood. Oxygen and carbon dioxide both diffuse until their partial pressures in the air and blood are equal. Inspiration delivers oxygen to the alveoli. Not all inspired air reaches the alveoli for gas exchange. Tidal volume is a measure of depth of breathing. The amount of air in millimeters that is moved into or out of the lungs during a single breath. Tidal volume for an average adult is 500 milliliters. So tidal volume, always remember that's the air in millimeters that's moved in or out of the lungs during a single breath. And your tidal volume for an average adult is 500 milliliters. Dead space, it's the portion of inspired air that fails to reach the alveoli. Exhalation, it does not normally require muscular effort, but rather is a passive process. The diaphragm and the intercostal muscles relax, which decrease the size of the thorax. The smaller thorax compresses air in the lungs into a smaller space. The air pressure in the thorax is then higher than the outside pressure. Air is pushed out through the trachea, and air can enter and leave the lungs only if it travels through the trachea. That is why clearing and maintaining a patent airway is so important. Regulation of ventilation involves a complex series of receptors and feedback loops that sense gas concentrations in the body fluids and sends messages to the respiratory center in the brain to adjust the rate and depth of ventilation. The body's need for oxygen is constantly changing. Failure to meet the need may result in hypoxia, an extremely dangerous condition. If you're watching this lecture, text me at an appropriate time what hypoxia is for your bonus point from this lecture. Failure to meet the need may result in hypoxia, an extremely dangerous condition. The tissues and cells do not get enough oxygen, and if it is not corrected, the patient may die quickly. Oxygenation is the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. It's required for internal respiration to take place. Oxygenation does not guarantee that internal respiration is taking place. Ventilation without oxygenation can occur in places where oxygen levels in the breathing air have been depleted, such as in mines or confined spaces. Respiration is the actual exchange of oxygen and carbon dioxide in the alveoli and in the tissues of the body. Cells take energy from nutrients through a series of chemical processes known as metabolism, cellular respiration. External respirations, also known as pulmonary respiration, brings fresh air into the respiratory system. It exchanges oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. Surfactant keeps the alveoli expanded, making it easier to perform gas exchange. Internal respiration, exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. Oxygen passes from blood in the capillaries to tissue cells. Carbon dioxide and cell waste pass from the cells into the capillaries, where they are then transported via the venous system back to the lungs. All cells need a constant supply of oxygen to survive. When there is adequate oxygen, cells convert glucose into energy through aerobic metabolism. Without adequate oxygen, anaerobic metabolism takes place, which cannot meet the metabolic demands of the cell. Pathophysiology of respiration, factors in the nervous system. Chemoreceptors monitor levels of oxygen, carbon dioxide, hydrogen ions, and the pH of cerebrospinal fluid and provide feedback to the respiratory centers. Your ventilation perfusion ratio and mismatch, your airflow, which is your ventilation, and your blood flow, which is perfusion, must be directed to the same place at the same time. Failure to match ventilation and perfusion is the cause of most abnormalities of oxygen and carbon dioxide exchange. When ventilation is compromised but perfusion continues, blood passes over some alveolar membranes without gas exchange taking place. This result is a lack of oxygen diffusing across the membrane into the blood circulation. Carbon dioxide is not able to diffuse across the membrane into the lungs and therefore recirculates within the bloodstream, which can lead to severe hypoxia. Factors affecting pulmonary ventilation. Maintaining a patent airway is critical. Intrinsic factors that can cause airway obstructions are infections, allergic reactions, unresponsiveness, the tongue obstruction during unresponsiveness, um, extrinsic factors that can cause airway obstructions are trauma or foreign body airway obstructions. Factors affecting respiration. Oxygen and perfusion need to function efficiently. External factors include atmospheric pressure and the partial pressure of oxygen in the environment. Internal factors include conditions that reduce the surface area for gas exchange and decrease the body's oxygen supply, leading to inadequate tissue perfusion. Examples: pneumonia, pulmonary edema, COPD, emphysema, those type things. There's a saying that we did when I was going through EMT, and I'm sure they still use it. Air goes in and out, blood goes round and round. Any deviation from this is a problem. So air goes in and out, blood goes round and round. Any deviation from this is a problem. Obstruction of blood flow to individual cells and tissue is typically related to trauma emergencies, creating circulatory compromise. Trauma emergencies can be like pulmonary embolism, simple or attention pneumothorax, an open pneumothorax, which is a sucking chest wound, a hemothorax, or a hemopneumothorax. Other causes of circulatory compromise is blood loss, anemia, hypovolemic shock, which is an abnormal decrease in blood volume, or vasodilatory shock, which is abnormal increase in blood vessel diameter, which decreases your blood pressure. Patient assessment. Recognizing adequate breathing. Signs of normal breathing in adults. Adults would have 12 to 20 breaths per minute, a regular pattern of inhalation and exhalation, bilateral clear and equal lung sounds, regular equal chest rise and fall, or adequate depth or tidal volume. Recognizing abnormal breathing, the patient would be breathing less than 12 breaths a minute or more than 20 breaths in a minute with the presence of shortness of breath, dyspnea. An irregular rhythm, diminished, absent, or noisy auscultated breath sounds, reduced flow of expired air at the nose and the mouth, unequal or inadequate chest expansion resulting in reduced tidal volume, increased effort of breathing where the patient is using like their accessory muscles, shallow depth, which would create decreased tidal volume, skin that is pale, cyanotic, cool, or moist, and skin pulling in around ribs or above the clavicles during inspiration, which we know as retractions. A patient may appear to be breathing after the heart has stopped. These occasional gasping breaths are called agonal gas. Cheyenne-Stokes respirations are often seen in patients with a stroke or a head injury. The breathing with increasing rate and depth of respirations, followed by apnea or a lack of spontaneous breathing. Ataxic respirations have an irregular or unidentifiable pattern and may follow a serious head injury. Patients experiencing a metabolic or toxic disorder may display other abnormal respiratory patterns, such as Kussmaul respirations. Kussmaul respirations are deep, rapid respirations commonly seen in patients with metabolic acidosis. Patients with inadequate breathing need to be treated immediately. Even though the patient may be ventilating appropriately, the actual exchange of oxygen and carbon dioxide at the tissue level may still be compromised by several factors: high altitudes, poisonous gases, including carbon monoxide, and enclosed spaces. A patient's level of consciousness and skin color are excellent indicators of respiration. When assessing a patient, consider proper oxygenation, which can be assessed by pulse oximetry. Oxygen saturation measures the percentage of hemoglobin molecules that are bound in arterial blood. A pulse oximeter measures the percentage of hemoglobin saturation. Your SpO2 should be between 98 to 100% while breathing room air. In conditions such as a stroke or a heart attack, oxygen is applied when the SpO2 is less than 94%. Pulse oximeters can take as long as 60 seconds to reflect changes in a patient's oxygenation status. The patient can develop respiratory insufficiency well before the pulse oximeter values begin to decline. Pulse oximetry is considered a routine vital sign and can be used as a part of any patient assessment. Causes of inaccurate pulse oximetry readings could be hypovolemia, severe peripheral vasoconstriction, time delay in detecting respiratory insufficiency, dark or metallic nail polish, dirty fingers, carbon monoxide poisoning. Pulse oximeters do not replace a complete assessment, and pulse oximeters cannot measure the effectiveness of ventilation or provide information about cellular metabolism. Opening the airway. Emergency medical care begins with ensuring an open airway. You're going to rapidly assess whether an unconscious patient has a patent airway and a pulse and is breathing adequately. You're going to position the patient in a supine position. An unconscious patient should be moved as a unit because of the potential for spinal injury. In an unconscious patient, the most common airway obstruction is the patient's tongue, which falls back into the throat when the muscles of the throat and the tongue relax. Head tilt chin lift maneuver will open the airway in most patients. For patients who have not sustained or not suspected of having sustained spinal trauma, this simple maneuver is sometimes all that is needed for the patient to resume breathing. Follow these steps. With the patient supine, position yourself beside the patient's head. Place the heel of one hand on the forehead and apply firm backward pressure with the palm. Place the fingertips of the other hand under the patient's lower jaw. Then you're going to lift the chin upward with the entire lower jaw, helping to help tilt the head back. Jaw thrust maneuver. If you suspect a cervical spine injury, you're going to use the jaw thrust maneuver. You're going to follow these steps. You're going to kneel above the patient's head. You're going to place your fingers behind the angles of the lower jaw. You're going to move the jaw upward, and you're going to use your thumbs to help position the jaw. There's a diagram. It kind of shows you your hand placements and where you're going to actually grip the patient's jaw at. All right, opening the mouth. Even though you may have opened the airway, the patient's mouth may be closed. You're going to place the tip of your index finger and your thumb on the patient's teeth. You're going to open the mouth by pushing your thumb on the lower teeth and your index on the upper teeth. The pushing motion will cause the index finger and the thumb to cross over each other, which is why this is called the cross finger technique. Suctioning. You must keep the airway clear to ventilate the patient properly. If the airway is not clear, you will force the fluids and secretions into the lungs and possibly cause a complete airway obstruction. If you hear gurgling, the patient needs suctioning. Suctioning equipment. You have a portable, hand-operated, and a fixed equipment that are all essential for resuscitation. A portable suction unit must provide enough vacuum pressure and flow to allow you to suction the mouth and the nose effectively. Hand-operated suctioning units with the disposable chambers are reliable, effective, and relatively inexpensive. A fixed suctioning unit should generate airflow of more than 40 liters a minute and a vacuum of more than 300 millimeters when the tubing is clamped. A portable or fixed unit should be fitted with the following: wide bore, thick walled, non-kinking tubing, plastic rigid pharyngeal suction tips called tonsil tips or Yonker tips. They're the best kind of catheters for infants and children. The large diameter plastic tips are rigid and do not collapse. Non-rigid plastic catheters called French or whistle tip catheters. They're used to suction the nose and liquid secretions in the back of the mouth and in situations when you cannot use a rigid catheter. They're non-breakable, disposable collection bottles and water supply for rinsing the tips. Techniques of suctioning. You're going to inspect your suctioning equipment regularly to make sure it's in proper working condition. To operate the suction unit, you're going to check the unit for proper assembly of all of its parts. You're going to turn on the suction unit and ensure that it has vacuum pressure. You're going to select and attach the appropriate suction catheter to the tubing. You're going to never suction the mouth or nose for more than 15 seconds at one time for adult patients, 10 seconds for children, and 5 seconds for infants. Suctioning can result in hypoxia, so you're going to rinse the catheter and tubing with water to prevent clogging. and you're going to repeat suctioning only after the patient has been adequately ventilated and reoxygenated. Do not touch the back of the airway with a suction catheter. This can activate the gag reflex. Sometimes a patient may have secretions or vomitus that cannot be suctioned quickly or easily, and some units cannot remove objects such as teeth, foreign bodies, and food. In these cases, you're going to remove the catheter from the patient's mouth. You're going to log roll the patient on the side. You're going to clear the mouth carefully with a gloved finger. If a patient who requires assisted ventilations produces frothy secretions as quickly as you can suction them, you're going to suction the airway for 15 seconds, which that's an adult, and it would be less for infants and children. And then you're going to ventilate for 2 minutes, and you're going to continue this alternating pattern of suctioning and ventilating until all secretions have been cleared from the airway. Basic airway adjuncts. An airway adjunct prevents obstruction of the upper airway by the tongue and allows for passage of air and oxygen to the lungs. Oropharyngeal airways keep the tongue from blocking the upper airway. Indications for an OPA: unresponsive patient without a gag reflex, apneic patients being ventilated with a BVM. Contraindications is a conscious patient, any patient, conscious or unconscious, who has an intact gag reflex. An oral airway that is too large could push the tongue back into the pharynx, blocking the airway. An oral airway that is too small could block the airway directly, like any foreign body obstruction. If you encounter difficulty inserting the oral airway, an alternative method may be used, inserting with a 90-degree rotation. Nasopharyngeal airways. They're used with patient who has an intact gag reflex but is unable to maintain his or her own airway spontaneously. Indications: semi-conscious or unconscious patients with an intact gag reflex, patients who otherwise will not tolerate an oral pharyngeal airway. Contraindications are severe head injury with blood draining from the nose or history of fractured nasal bones. Maintaining the airway. The recovery position is used to help maintain a clear airway in an unconscious patient who is not injured and is breathing on his or her own with normal respiratory rate and adequate tidal volume. Supplemental oxygen. Always give supplemental oxygen to patients who are hypoxic because not enough oxygen is being supplied to the tissue cells of their body. Some tissues and organs such as heart, central nervous system, lungs, kidneys, and liver need a constant supply of oxygen to function normally. You never withhold oxygen from any patient who might benefit from it, especially if you must assist ventilations. Supplemental oxygen equipment. Your oxygen cylinders. The oxygen that you will give to the patients is usually supplied as a compressed gas in green steel or aluminum cylinders. Check that cylinder is labeled for medical oxygen. Look for letters and numbers stamped into the metal on the collar of the cylinder. Check the month and year stamps indicating when the cylinder was last tested. And aluminum cylinders are tested every 5 years. Composite cylinders are tested every 3 years. Most often, the D cylinder sizes will be used as portable tanks, and the length of time you can use an oxygen cylinder depends on the pressure in the cylinder and the flow rate. Your liquid oxygen is becoming a more commonly used alternative to compressed gas and oxygen. Your safety considerations for oxygen, you're going to handle your gas cylinders carefully because the contents are under pressure. You're going to make sure the correct pressure regulator is firmly attached before transporting the cylinder. A puncture or a hole in a tank can turn into a deadly missile. You're going to secure cylinders with mounting brackets when they are stored on the ambulance. And oxygen cylinders that are in use during transport should also be properly secured. Pin indexing system. Each cylinder of a specific gas type has a given pattern and a given number of pins, following accepted national standards. This pin indexing system prevents an oxygen regulator being accidentally connected to an incorrect gas cylinder. When preparing to administer oxygen, check the pinholes on the cylinder exactly match the corresponding pins on the regulator. For large cylinders, the safety system is the American Standard Safety System. Your oxygen cylinders are equipped with threaded gas outlet valves, and inside and outside thread sizes vary depending on the gas in the cylinder, preventing accidental attachment of a regulator to the wrong cylinder. Pressure regulators. Pressure regulators reduce the cylinder's pressure to a useful therapeutic range for the patient, usually 40 to 70 psi. After the pressure is reduced to a workable level, the final attachment for delivering the gas is one of the following: a quick connect female fitting that will accept a quick connect male plug from a pressure hose or ventilator, or a flow meter that will permit the regulated release of gas measured in liters per minute. Flow meters are usually permanently attached to pressure regulators on emergency medical equipment. A pressure compensated flow meter incorporates a float ball within a tapered, calibrated tube. It is affected by gravity and must always be upright. The Borden gauge flow meter is a gauge calibrated to record flow rate. It can be used in any position. Combustion. Oxygen does not burn but does speed up the combustion process. A small spark, such as a glowing cigarette, can become a flame. Keep any possible source of fire away from the area while oxygen is in use. Make sure that the area is adequately ventilated, especially in industrial settings, and never leave an oxygen cylinder standing unattended. Oxygen toxicity. Not all patients require high-flow oxygen. Excessive supplemental oxygen can have detrimental effect on patients with certain illnesses, such as COPD, bronchopulmonary dysplasia. Oxygen toxicity refers to damage to the cellular tissues due to excessive oxygen levels in the blood. Increased cellular oxygen levels contribute to the production of oxygen-free radicals, which can lead to tissue damage and cellular death in some patients. The International Liaison Committee on Resuscitation Guidelines, published by the American Heart Association, recognize there may be negative effects of oxygen toxicity and recommend that oxygen be administered to patients experiencing signs of myocardial infarction when they have signs of heart failure are short of breath, or have a room air oxygenation saturation less than 94%. Patients experiencing signs of shock should be placed on oxygen. Hypoxemia is much worse than oxygen toxicity. When in doubt, or if unable to measure oxygen saturation reliably, supplemental oxygen should be administered. When the pulse oximetry is available, tailor oxygen therapy to the patient's needs and administer the minimum amount of oxygen necessary to maintain oxygen saturation at or above 94%. Oxygen delivery equipment. In general, oxygen delivery equipment used in the field should be limited to non-rebreathing masks, BVMs, and nasal cannulas. Non-rebreathers combine a mask with a reservoir bag system. The oxygen fills the reservoir bag attached to the mask by a one-way valve. Exhaled gas escapes through the flapper valve ports at the cheek areas of the mask. These valves prevent the patient from rebreathing exhaled gases. You're going to make sure the reservoir bag is full before placing the mask on the patient. You're going to adjust the flow rate so the bag does not collapse when the patient inhales, usually 12 to 15 liters. If the bag does collapse, you're going to increase the flow rate. When oxygen therapy is discontinued, remove the mask from the patient's face. It's available in adult, pediatric, and infant sizes. Nasal cannulas. They're going to deliver oxygen through two small tube-like prongs that fit into the patient's nostrils. They can provide 24 to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. For patient comfort, flow rates above 6 liters are not recommended. A patient who breathes through their mouth or has a nasal obstruction will get little oxygen. Some EMS systems provide humidified oxygenation during extended transport. Dry oxygen is not considered harmful for short-term use. There's your non-rebreathing mask, the combination mask, and the reservoir bag mask system. There's your picture right there. Your nasal cannula. I've already read this. I'm just catching up on slides. All right, here we are. Tracheostomy mask. The patient with tracheostomies do not breathe through their mouth or nose. Tracheostomy masks cover the tracheostomy hole and have a strap that goes around the neck. They may not be available in an emergency setting, in which you should improvise by placing a face mask over the stoma. Assisted and artificial ventilation. Basic airway and ventilation techniques are extremely effective when administered appropriately. Signs and symptoms of inadequate ventilation include altered mental status, inadequate minute volume, or excessive accessory muscle use and fatigue. A bag valve mask, commonly called a BVM, is the most common method used to ventilate patients in the field. With an oxygen flow rate of 15 liters per minute, a BVM can deliver nearly 100% oxygen. It can deliver only as much volume as you can squeeze by hand. A BVM provides less tidal volume than mouth-to-mouth ventilation, but delivers a much higher concentration of oxygen. A BVM components: a disposable self-refilling bag, no pop-off valve or disabled pop-off valve, non-rebreathing outlet valve, an oxygen reservoir that allows for delivery of high concentration oxygen, one-way, no jam inlet valve with flow of up to 15 liters per minute, transparent face mask. To assist a patient with ventilation using a BVM, you're going to explain the procedure to the patient. You're going to place the mask over the patient's nose and mouth, and you're going to squeeze the bag each time that the patient breathes, maintaining the same rate as the patient. After the initial 5 to 10 breaths, you're slowly going to adjust the rate and deliver an appropriate tidal volume. You're going to adjust the rate and tidal volume to maintain an adequate minute volume. Artificial ventilation. Patients in respiratory arrest need immediate treatment to live. Once you determine that your patient is not breathing, you're going to begin artificial ventilation immediately. Methods are going to be mouth to mask, which we do not use anymore, BVM, but for National Registry, you do need to know that the mouth to mask technique. I would not suggest a mouth to mask technique these days. BVM, manually triggered ventilation device. Normal ventilation versus positive pressure ventilation. So, artificial ventilations are necessary to sustain life, but are not the same as normal breathing. In normal breathing, the diaphragm contracts and negative pressure is generated in the chest cavity, which sucks air into the chest. Positive pressure ventilation generated by a device forces air into the chest cavity. Complications of positive pressure ventilation. It's going to increase your intrathoracic pressure, causing compression of the vena cava and reducing the blood return to the heart, which in turn reduces the amount of blood pumped by the heart. More volume is required to have the same effects as normal breathing, which pushes the airway walls out of their normal anatomic shape. And air is forced into the stomach, causing gastric distension that could result in vomiting and aspiration. The EMT must regulate the rate and volume of artificial ventilation to help prevent the drop in cardiac output. Ventilation rates for apneic patients with a pulse. Adults, 1 breath per 5 to 6 seconds, and infant and child is 1 breath per 3 to 5 seconds. Mouth to mouth and mouth to mask ventilation. A barrier device is routinely used in mouth-to-mouth ventilations. A barrier device is a protective item that features a plastic barrier placed on a patient's face with a one-way valve to prevent the backflow of secretions, vomitus, and gases. Mouth-to-mouth ventilations without a barrier device should only be provided in extreme situations. A mask with an oxygen inlet provides oxygen during mouth-to-mask ventilation. It supplements the air supplied by the lungs, and with the mouth-to-mask system, patients get the benefit of significant oxygen enrichment. To increase the oxygen concentration, administer high-flow oxygen at 15 liters a minute through the oxygen inlet valve of the mask to deliver about 55% oxygen. Bag valve mask, it's going to provide less tidal volume than mouth-to-mask ventilation, but it delivers a much higher concentration of oxygen. An experienced EMT can provide adequate tidal volume. When using a BVM or any other ventilation device, be alert for gastric distension. Make sure your belly don't rise. If you have difficulty adequately ventilating a patient with a BVM, switch immediately to another method such as the mouth-to-mask technique. The volume of oxygen delivered is based on observing chest rise and fall. Gastric distension. It occurs when artificial ventilation fills the stomach with air, most likely to occur when you ventilate the patient too forcefully or too rapidly with a BVM or a pocket mask. The airway is obstructed as a result of a foreign body or improper head position. You're going to give slow, gentle breaths during artificial ventilation over 1 second. Ventilate the patient at the appropriate rate. You're going to ventilate the patient with the appropriate volume. If gastric distension makes it impossible to ventilate the patient and an ALS provider is not available to perform decompression, considering applying pressure over the upper abdomen as a last resort. If vomiting occurs as a result, turn the patient's entire body to the side, suction and or wipe out the mouth with your gloved hand, return the patient to a supine position and continue rescue breathing. Manually triggered ventilation devices, also known as flow-restricted, oxygen-powered ventilation devices, allow a single rescuer to use both hands to maintain a mask-to-face seal while providing positive pressure ventilation. Disadvantages may be difficult to maintain adequate ventilation without assistance and should not be used routinely because of high incidence of gastric distension and possible damage to structures within the chest cavity. A special unit and additional training are required for infants and children, and they should not be used with COPD or suspected cervical spine or chest injuries. Automatic transport ventilator resuscitator. The ATV is a manually triggered ventilation device attached to a control box that allows the variables of ventilation to be set. It frees the EMT to perform tasks such as maintaining the mask seal or ensuring continued airway patency. Constant reassessment of the patient is necessary. Continuous positive airway pressure is non-invasive ventilatory support for patients experiencing respiratory distress. Many people diagnosed with obstructive sleep apnea wear a CPAP unit at night to maintain their airways while they sleep. CPAP is becoming widely used as an EMT. Mechanism. CPAP increases the pressure in the lungs. It's opening the collapsed alveoli and it pushes more oxygen across the alveolar membrane and it forces interstitial fluid back into the pulmonary circulation. The therapy is typically delivered through a face mask held to the head with a strapping system. A good seal with minimal leakage between the face and mask is essential. Many CPAP systems use oxygen as the driving force to deliver the positive ventilatory pressure to the patient. Use caution with patients with potentially low blood pressure because CPAP causes a drop in cardiac output. Indications for CPAP: the patient is alert and able to follow commands. The patient displays obvious signs of moderate to severe respiratory distress from a condition such as pulmonary edema or obstructive pulmonary disease, example like COPD. The patient is breathing rapidly, such that it affects overall minute volume greater than 26 breaths a minute. Pulse oximetry is reading less than 90. Contraindications: that the patient is in respiratory distress, signs and symptoms of a pneumothorax or chest trauma, a patient who has a tracheostomy, active gastrointestinal bleeding or vomiting, a patient who is unable to follow verbal commands. In addition to these contraindications, always reassess the patient for signs of deterioration and or respiratory failure. Application. Components of your CPAP. It's going to be the generator, your mask, the circuit continuing corrugated tubing, a bacteria filter, and a one-way valve. The CPAP generator creates resistance throughout the respiratory cycle. Um, the resistance creates a back pressure into the airways that pushes the smaller airway structures, such as the bronchioles and alveoli, as the patient exhales. The amount of pressure can be determined by adjusting a valve within the CPAP system or with a separate valve that can be attached. A pressure of 7.0 to 10.0 is generally an acceptable therapeutic range. Since most CPAP units are powered by oxygen, it is important to have a full cylinder of oxygen when using CPAP. Complications. Some patients may find CPAP claustrophobic and will resist the application of the mask. You're going to coach your patients through the process rather than forcing the mask on them. Due to the high volume of pressure generated by CPAP, there is a possibility of pneumothorax. High pressure in the chest can lower a patient's blood pressure. If the patient shows signs of deterioration, remove the CPAP and begin positive pressure ventilation using a BVM attached to high flow oxygen. Special considerations, stomas and tracheostomy tubes. Patients who have had a laryngectomy, surgical removal of the larynx, have a permanent tracheal stoma, which is an opening in the neck that connects the trachea directly to the skin, known as a tracheostomy. If the patient has a tracheostomy tube, ventilate through the tube with a VVM. A standard adapter on the VVM will fit onto the tube in the tracheal stoma. Use 100% oxygen attached directly to the VVM. If the patient has a stoma but no tube is in place, you're going to use an infant or a child mask with your BVM to make a seal over the stoma. You're going to seal the patient's mouth and nose with one hand to prevent leak of air through the upper airway when you ventilate through a stoma. You're going to release the seal of the patient's mouth and nose for exhalation. This will allow the air to exit through the upper airway. If you cannot ventilate a patient with a stoma, try suctioning the stoma and the mouth with a French or soft tip suction, and you're going to seal the stoma while giving mouth-to-mouth ventilation. Airway obstruction. If an obstruction completely blocks the airway, it is a true emergency. It will result in death if not treated immediately. In an adult, sudden foreign body airway obstruction usually occurs during a meal. In a child, it can occur while eating, playing with small toys, or crawling around the house. By far, the most common airway obstruction in an unconscious patient is the tongue, which relaxes and falls back into the throat. Causes of airway obstruction that do not involve foreign bodies: swelling from infection or acute allergic reaction. Repeated attempts to clear the airway could be dangerous. These patients require specific emergency medical care. Rapid transport to the hospital is critical. And then trauma can also cause airway obstructions, like tissue damage from an injury, teeth being knocked out, things like that in a child can cause airway obstructions. Mild airway obstruction. Patients can exchange air, but will have varying degrees of respiratory distress. Great care must be taken to prevent a mild airway obstruction from becoming a severe airway obstruction. The patient may have noisy breathing and may be coughing. With good air exchange, the patient can cough forcefully, although you may hear wheezing between coughs. As long as the patient can breathe, cough forcefully, or talk, you should not interfere with the patient's efforts to expel the foreign object on his or her own. With poor air exchange, the patient has a weak, ineffective cough and may have increased difficulty breathing. Stridor and cyanosis. Now, stridor is a high-pitched noise heard mainly on inspiration. Stridor indicates mild upper airway obstruction, and you're going to treat immediately as if there was a severe airway obstruction. Stridor is one of those that I recommend you pull up on YouTube and listen to, just so you know. Severe airway obstruction. Patients cannot breathe, talk, or cough. The patient may clutch or grasp the throat, which is the universal distress signal, began to turn cyanotic, and have extreme difficulty breathing. There is little or no air movement, and if the patient is found unresponsive, does not appear to be breathing, and does not have a pulse, begin CPR with high-quality chest compressions. When you open the airway and attempt 2 ventilations following chest compressions, it will be obvious if the airway is blocked, if there is no chest rise or fall after several attempts, or if you feel resistance while ventilating, consider the possibility of an airway obstruction. If the patient is found unresponsive, not breathing, and has no pulse, begin CPR with chest compressions, high quality chest compressions. Emergency medical care for foreign body airway obstructions. You're going to perform a head tilt chin lift maneuver to clear a tongue obstruction. If spinal trauma is suspected, you're going to open the airway with the jaw thrust maneuver. Large pieces of vomited food, mucus, loose dentures, or blood clots in the mouth should be swept forward and out of the mouth with your gloved index finger. When available, perform suctioning to maintain a clear airway. Abdominal thrust, her most effective method of dislodging and forcing an object out of the airway of a conscious patient. Residual air, which is always present in the lungs, is compressed upward and used to expel the object. Use the abdominal thrust until the object is dislodged or the patient becomes unconscious. For the unresponsive patient with a severe body airway obstruction, reassess to confirm apnea and inability to ventilate. Begin chest compressions just as you would for CPR, following the 30 compressions to 2 ratio. At the completion of 30 compressions, you're going to pull the jaw mouth open and look in the back of the oropharynx for any foreign objects. If you see an object, remove it with a glove index finger or suction. Never perform a blind sweep of the back of the oropharynx, which may push an object farther down in the airway, making the obstruction worse. Once the object is removed, or if no object was seen, attempt to ventilate. If you are still unable to ventilate, repeat the process. Dental appliances. Many dental appliances can cause an airway obstruction. Examples, a crown, a bridge, dentures, or a piece of braces. You're going to manually remove the dental appliance before providing ventilations. Leaving well-fitted dentures in place usually makes a BVM or mouth-to-mouth ventilation much easier. It provides more structure to the face and helps you provide a good face-to-mask seal. Loose dentures may interfere with the process and should be removed. If possible, place dislodged dentures in a container and transport them with the patient. Facial bleeding. Airway problems can be particularly challenging in patients with serious facial injuries. The blood supply to the face is very rich, so injuries can result in severe tissue swelling and bleeding into the airway. Control bleeding with direct pressure and suction as necessary. Alright, guys, we are done. I'm sorry, I know that it's probably not the best, but it is 1:30 a.m. and I have attempted to stay awake to get these done for y'all after a very long day. If you have any questions concerning this chapter before your test on Monday, please feel free to reach out to any of the instructors. We are here for you. We want to help you guys any way that we can. Remember, Quizlet's your friend. Um, any help that we can be, just let us know.